after our last class, because I had started to get some inquiries about the content of exam 2, so that you forward thinkers could start making some sense out of, I guess, your time management. What it said, and I think some people have read it and still not quite clear, is that we will, the next exam will include innate immunity and specific immunity. And I think that's chapters 14 and 15. And when we finish 15, we will start into 16. And obviously we will not be able to complete that in a class period. So I will tell you at the end of tomorrow, for sure, what, if any, of chapter 16 will be on the exam 2. You notice that we're going back in time, not in time, but we're going back in chapters to capture chapter 12, and that's on antibiotics. I won't be here next week. I'm taking my daughter on her first cruise. Actually, it's my first real cruise too. We're going to be going to the northeastern coast of the U.S. and Canada to do the change in the seasons cruise, and we'll be taking little ports of call along the way. So that's going to be fun. It's going to be chilly, so I'll take pictures and I'll share when I come back. And it's a Jim Brickman cruise. Any Jim Brickman and piano aficionados, kind of a music junkie. And keyboards and strings are my favorite, so that'll be fun too. So we got music and cool and change of seasons, nature and beauty and all that stuff, and no micro.
Yeah.
But you can't be without micro. So Professor Paola is going to teach the chapter 12 on the way. And he'll have 2 class periods to do that. So 4 hours, so be ready. And so his content will be on the exam on Tuesday the 15th. And when I get back, we'll continue to charge through as much material as we can. And you see, I've just made this chapter just one giant PowerPoint instead of having like a half dozen. We could have easily made this into to many different sections, but I'd rather just call it lecture 7, but take the time we need to get through it and call it one chapter and 1 unit. So we're getting kind of sort of close. At least we're closer to the end than the beginning now. So this is where we left off last time. We were talking about the differences in the different classes, isotypes of antibiotics. And if we draw blood, the antibiotics are in the serum portion. And if we electrophoresis or subject the serum to an electrical charge, the elements of the serum will move according to their charges and settle in certain areas. And you see the big blip is in the gamma area, closest to the negative charge, and most of the IgG is in that area. IgM is in there too, and so that's why they got called gamma globulins. So that's kind of how they settle out. And the big blip down there towards the positive end, that's the albumin, big protein component of our serum as well. Okay, we've we've talked about this on and off, and now it's really its time to hit the stage. This primary and secondary or memory feature of the specific immune response. The primary response is what happens, how our immune system responds when it had its first exposure to some non-self antigen. First time it gets to see it. And it mounts what we call a primary response. And we said that the class of immunoglobulins that's produced first is of the IgM class. And we're happy about that. There's some good reasons why IgM is a good first responder. Its anatomy makes it a good first responder. It's got all those hands that it can go out and try and settle down the problem by grabbing onto whatever's invading. So the amount of IgM that's in the serum can be measured, and it's measured, it's given as kind of a concentration, and that's called a titer, an antibody titer. And over time, as the immune system has more and more time to generate a response and get more plasma cells into the business of making a specific antibody to that antigen, the antibody titer gradually increases. So the concentration of antibody over time increases. And then the next responder is IgG. We said that IgM has a short half-life. It gets us through the initial attack, and then the IgG takes a bit longer to be produced, but when it is produced, it's produced for a longer period of time and at higher concentration. Okay. The secondary response is what the immune system does on second or subsequent exposure to that same antigen. Now we've seen this one before, and because we've generated memory, what kind of antigens are the ones that generate memory? What's a feature that we said of antigens that allow for the memory cells to be produced?
They're large.
They're large. And what about their largeness makes them likely to produce memory?
They're more antigenic.
More what? More antigenic. What something happened right here? What was it? Multiple epitopes could be a reason, yes. But there's something about the way the immune response handles a bigger antigen that enhances the ability to have memory. Remember what that was? All of that's the same, whether it's big or small. It's going to take it in, it's going to chop it up, and it's going to try to present it on the surface. There's something else that's important for the production of memory.
Are you looking for oxidation?
No?
Okay.
Try again. Something about the memory response that's required for this memory thing to happen. More clues?
Yeah.
Yes. Yeah.
Okay. We said that as the immune system recognizes non-self, and it starts to do this thing, it starts to respond, to try to protect the host, there's something that happens that says, okay, I need to make memory. Make memory cells, make memory cells. What is it the thing that says make them? Start right now, do it. I'm telling you to do it.
Interleukin release,
By what?
helper T cell.
Yay!
Nice.
Okay, so now, whew, see, I know it's in there somewhere. Just gotta chisel it out. Okay, so memory T cells are only engaged in response to certain kinds of antigens, right? And we call those kinds of antigens T what? T blah 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 resolvable antigen. Blah blah blah. Anybody else teach you like that? T,
Dependent.
yeah, dependent, blah, blah, blah. T-dependent and antigens are the ones that require the interaction of those T cells. The T cells now are going to start squeezing out those cytokines and those interleukins that are required to say, memory cells, do your thing. And we said that memory T cells are not absolutely required for making antibodies. But when they're not involved, fill in the blank. When T cells are not involved in the formation of antibody, fill in the blank.
You're not gonna have memory for this?
We're not going to have memory. That's right. So the next time, the second and subsequent times that we're exposed to that antigen, we have to go through this IgM thing again, and we have to go through the same slow, inefficient process again. Okay. So the interaction of T helper cells in this process makes the immune system much, much more efficient, and it protects the host much better, because in the second and subsequent exposure to an antigen, because of memory, the host may not even recognize that it came in contact with this bad thing, because there's so much antibody around in the circulation. Remember, IgG is going to be there. And once the memory cells are aroused, saying, oh, look, that's our antigen, it's going to just start squeezing out lots of IgG and very quickly. And that's the anamnestic response. Okay, so here we go. A successful primary immune response means that we need more of the B cells that have that specificity for the antigen. So we need more of those B cells to be produced. That's another thing that those interleukins do that come from helper T cells. Okay. So this second, the second bullet point is pretty much what happens when there is no T cell requirement. They're small, not very immunogenic, not very antigenic substances come into the body. The B cells do their things, they make some antibody, but the B cells themselves are they have a half-life, they have a short lifespan. They will grow into plasma cells, squirt out some antibody, and then they're done. Okay? So when we have this memory, we have B cells who have already been through this process, and they remember that they've been through this process, and then they get to respond to the antigen the second and third and fourth time much more quickly and much more efficiently. Okay? So primary responses are slow. We have to go through this. Let's make some IgM. Let's wait for the IgG titers to get big enough to have a protective effect on the host. Okay? So memory speeds things up, makes things better for the host when the host has seen this particular antigen before. Okay? So this describes that process. Reinfection means second or subsequent encounter with that antigen that the immune system has seen before. It's fast, it's efficient, and we may not even know that we've been reinfected with something that made us pretty sick the first time around. Those memory B cells now, they're hanging out in lymphoid tissues, but once they detect the antigen that they were created to respond to, they just turn into plasma cells really quickly and start to secrete their specific immunoglobulin. Now, second and subsequent, B cells start the memory B cells are awakened and back into the game. We have a new clone of B cells that are ready to do the job of fighting against this antigen. We get more quick production and we get greater amounts of antibodies. And this time we get even more memory cells produced. Okay? So we have a longer period of protection. So the third or fourth time, we really may not know that we were ever exposed. Primary response to a new antigen, that means this is the first time the body's seen it. The response is going to peak something like 4 to 5 to 10 days to get, the processing, the presenting on the surface, and the T cells to recognize the antigen or the epitopes on the surface of the MHC2 and all that stuff. IgM is formed, later IgG is formed. All of that takes time. When we're dealing with memory and the anamnestic response, we get 1 to 3 days, we're squeezing out antibodies and lots of it, and the host is protected. Now you notice we can sometimes, depending on what the antigen is and where the exposure occurs, if the exposure occurs in the GI tract or something like that, you'll expect that you're going to have IgA form. And if we're having a hypersensitivity reaction, or we're re-exposed to an antigen that the host is allergic to, you can expect that we're going to start making IgE in response. Okay, primary response. Host has never seen this antigen, this pathogen, this invader before. So in the serum, we have essentially no antibody against that thing. The body's never had any reason to make antibody against it. So it's going to take us some time. Remember, we talked about all of the opsonization and all of that stuff, and bringing it in and breaking it up and presenting it, and all that stuff takes some time. We're going to have a primary response, and mostly it's an IgM response at first, and later on we're going to get IgG produced, and it's going to level off. But during this time, we're going to have all these memory cells are being produced. Your host gets better, and everything is right with the world. Sometime down the line, this is days, a few months later, we're encountering the same antigen again, but because of memory, we're going to get a big uptick quickly of antibody, mostly IgG, Doesn't mean that IgM, all that slow IgM stuff is not happening, because it is. But it's just not as important in the, in a secondary, response, and we'll see that, in a bit as well. Okay, this is stuff that you already know. Just saying it again, over and over and over. So when I start dancing up and down here, you'll start to say, yeah, I know that, sure I know, yeah, this is what happened. Okay, so, secondary response, we get an expansion of that clone of B cells that were born to respond to this particular antigen. They recognize it on their B cell receptors. And the B cell receptors are made out of what?
Antibodies.
And what kind? And
And
what kind of M?
mono.
Monomeric, right. Very good. See? I dance out here long enough, we get this stuff. Okay, so now we have a pool of memory cells that hang out in the lymph nodes, in Malt and Dalt and Salt and all those places, waiting to encounter the antigen again. It may, and it may be that the host never sees that antigen again. But the memory cells will be there. They have a very long lifespan, and they'll replicate, and they'll just kind of hang out in the lymphoid tissue, hoping for an opportunity to get out there and do their thing again. We said that not only B cells have memory, but T cells have memory too. T4, CD4 memory cells. So we have an accelerated ability to help as well. This is what you just taught me about T-dependent antigen. And we said that T-independent antigen don't have the capacity to create memory cells. Now this is an interesting concept. We're saying systemic infection. So this patient was really, really sick with something. Let's say it was something like measles. It was a non-immunized child. Chickenpox. One of those things. Not chickenpox, because that has its own. We'll talk about that later. So kid had a systemic infection, really sick. And got over it and did the whole memory deal. Or, you notice, they said, or you get a vaccine. When you're a baby, you get one at 2 months, 4 months, 6 months, you get a booster at 18 months, and then you get another one, at 4 years before you go to school. And one of the things that happens to confer long-term immunity is that plasma cells, not just memory cells, will migrate to now the bone marrow. And they're just hanging out in the bone marrow for years and years and years sometimes. And they're in there and they're just squirting out small amounts of antibody all the time. So that the kid who had measles when there were 3, if you drew his blood and when he was 13, you would still be able to detect antibodies in his circulation, even when he's 13. Now, if you took a sample of serum from his blood when he was 7, and you measured the titer of antibody against the measles, and then at 13, you measured the titer of antibody against measles, what would you expect? When you compare the titer when you took it when he was 7 and when you took it when he was 13, what might you expect? These are just things to ponder. I haven't taught you this yet, but what do you think? He had measles when he was 3. At 7, you drew his blood and said, let's see how much protective antibody he's got. Okay?
Maybe it's slowly decreasing over time, that's why people don't take boosters.
Exactly right. He will have some protection, but he may not have the titer in his blood that's protective enough so that if he got exposed, he wouldn't even know he was sick. He might have enough so he wouldn't be as sick as he was when he was 3, but you want him to, at these intervals that we know the levels are starting to go down to below a protective level, that we get them back in and we get them re-boosted, come in and get their booster, and then we get a big uptick again because we wake up the memory cells. And we repopulate the bone marrow with brand new plasma cells to squirt out antibodies. Same thing, reason why we have to go every 10 years and get our tetanus booster, because our immunity wanes over the years. And they come up, they do all these evaluations of serums at this point in this year, and they notice that, well, typically, statistically speaking, most of the population is going to go below a protective titer at this time, so we get them in a year or 2 before that to make sure if they get an exposure, they're okay. So good. So you guys do know stuff, even if I haven't taught you yet. Okay. Another interesting feature of the immune response, and it's memory. It says memory is better at preventing systemic rather than mucosal infections, because infections limited to the mucous membranes usually don't provide enough time for the development of effector plasma cells and all those things, and to get them back in the bone marrow and all that kind of thing. What we know about mucosal infections is typically they're pretty short-lived. The turnover of mucosal cells is really fast. And we know that we have all of those cells that are cranking out the IG, secretory IgA, and usually it doesn't give a long enough exposure systemically, because usually it's localized where the infection and where the immune system is doing its thing. So you're more likely to get things like a conjunctivitis against the same had this virus, I got conjunctivitis again, because mucosal infections just don't confer very good long-term immunity. When I was in pediatrics, I was never sick. You just get to be, pediatricians or pediatric PAs who are around infections. You're getting sneezed on and coughed on and pooped on and vomited on and everything possible. You're just getting little bitty vaccinations all the time. You're just getting re-exposed, and your memory cells are just, you're just a big vault of memory cells, okay? And your plasma cells are all squirting out all kinds of stuff all the time. PA students who go into a pediatrics rotation are sick all the time because they are getting little vaccinations of stuff they've never seen before. Their plasma cells don't know anything about these things, so expect to be sick on pediatrics. But if you hang in there a while, you're just never sick. And I was never sick as a pediatrician except conjunctivitis. I had conjunctivitis. I mean, you just don't get, I'm living proof that this bullet point is very, very true. I know I've been sneezed on this same rhinovirus over and over and over again, or I touched something and touched my eye, or whatever. But that was the only thing I ever got. Garamycin, ophthalmic drops, always in the refrigerator because I was always gonna need it. And that is the reason. That's the explanation for why I was exposed to terrible things but wouldn't be sick with them, because circulation was protected, but my, individual mucosal membranes not so much. Okay, remember we saw the first little graph that just showed nothing, uptick, and then you're re-exposed, and then you get this big blast of response. This is kind of what happens under the surface. So you see, although we give credit to IgG as being the big player in the anamnestic response, because it just starts to happen almost immediately after a second or subsequent exposure to antigen, and that's really what's giving us most of the protection. You see that the IgM is still active. We're still making IgM even in a secondary response. So there will be some B cells and some dendritic cells that are reacting with the helper T cells just like normal. It just doesn't stop, because, we've already seen this infection before, we don't need to do that. Yes, it's just less important. The titer IgM is less important to protecting the host second and subsequent exposures. Really important in an initial exposure, because there is a time when all you have is IgM, while the rest of the immune system is revving up to be able to transfer into the production of IgG. IgM for a time is our protection, so it's very important in the initial response, really not so much in the secondary response. So if you had to choose which antibody is more important in a primary response, you'd say IgM is, and if you'd say which is more important in the secondary response, you'd say IgG. They're both involved in both places, but their prominence and their importance is different. Notice we have this latent period where the first responders are coming into contact with antigen, they're breaking stuff up and they're presenting it on the surface, and we just don't have a whole lot of antibody activity, but it doesn't mean the immune system is not doing anything. It just takes a while before we get an appreciable amount of antibodies in the system. And we know all about this stuff. You know even much more. This is very simplistic in comparison to what you know already. This is just showing you that's a long time, and all this stuff has to happen below the surface. But over here, we get a quicker response because we're not so much dependent on this and these initial reactions were because we have these guys that are ready to go to work and start squirting out IgG. Okay. Oh, monoclonal antibody. I love monoclonal antibodies. But I know a lot of strange things. Monoclonal antibodies are ones that we prepare in the laboratory to treat a very specific illness based on a very specific antigen. You make them from a single clone of plasma cells that are going to give you a single, very, very specific antibody against a very, very specific antigen. So when we make monoclonal antibody, it's pure. It's a pure preparation of antibody against a given antigen. And we make these in the laboratory using mouse B cells. And they have many, many different uses. And I'm really happy that these are, that this technology has been discovered, and we're moving farther and farther into our knowledge of how to do this and how to treat disease. Just think, if one thing we know about humans and aging is that if you live long enough, you're probably going to have some sort of production of tumors that have just gone, cells that have just gone mad and starting to produce tumors, and the longer you live, the higher your risk of developing some sort of a cancer. So let's say we got to be 150 years old and finally we got our cancer. Wouldn't it be a wonderful thing if we could take that cancer, an antigen from that cancer, make an antibody to it, and then squirt that antibody into our bodies and say, go get that antigen? That's pretty much how monoclonal antibodies work. It's not going to destroy the rest of your body. It's not going to be toxic to your heart. It's not going to make your hair fall out because it's so, toxic to your follicles and those kinds of things. It's going to be very specific to the antigen that we are looking to destroy. Let's see how we make them, and then we'll talk about them.
Monoclonal antibody preparations contain only one type of antibody, derived from a single cloned B cell. Consequently, they are highly specific for a single epitope and have applications, for example, in diagnostic microbiology and cancer therapy. The first step in producing a monoclonal antibody is to inject an animal with an antigen containing the specific epitope of interest. Each B cell produces a single type of antibody. B cells are isolated from the spleen and then mixed with myeloma cells, a type of cancer cell that grows continuously. Addition of polyethylene glycol causes the two types of cells to fuse together to form cells called hybridomas. The mixture of B cells, myeloma cells, and hybridomas are cultured under conditions which permit growth of only the hybridoma cells. Each hybridoma cell will produce a single type of antibody against a single epitope. The single hybridoma cells are then separated into individual wells of a microtiter plate and tested for ability to produce the desired antibody. The hybridoma cells producing the desired monoclonal antibody are then cultured. Monoclonal antibodies are isolated and purified.
Okay, so that was a pretty video way of describing, giving us an overview of how to make these things. So you know a lot already. So let's just go through this chart, which has more words, and I learn better when I have words and pictures. So remember, we take the mouse and we inject it with the antigen that we are interested in making antibody against. Then we have to sacrifice the mouse, and we remove its spleen. Okay? And we have to get its spleen cells all separated, because the spleen is where the antibody producing cells are. So myeloma cells are these tumor cells. We have to use myeloma cells because in the laboratory we can't get the mouse spleen cells to grow. We can't make more of themselves. To make that happen, they figured out if you fuse the myeloma cells to the spleen cells, you get these hybridomas, and the hybridomas can multiply and multiply and multiply and multiply because you want to make a lot of this antibody when you figure out which is the proper hybridoma to do it. So you fuse these things, you make the hybridomas, and you grow the hybridomas. The only cells that are going to grow in the culture are the hybridoma cells. Any spleen cells that didn't fuse, or there was some stray sort of cells in there, they're not going to grow. So after you get these hybridomas growing, you put them in individual wells, and you culture them in a way that's going to be favorable for them to start making the antibody that those particular antibody-producing cells were specific for. Okay? And then they have to figure out, well, which of these hybridomas in which of these wells is making the antibody against the antigen that we're interested in. So they have to do some testing in the wells to make sure it's the right antibody. And once they figure out which hybridomas are doing what they want, they'll culture them specifically, so we can make lots and lots of buckets of these things, so we get the pure sample of the antibody against the antigen that we're looking for in the first place. You see that another thing, that when we figure out the cells that are doing what we want them to do, we can keep the hybridomas growing and healthy by injecting them into the mouse, and so the mouse can hold on to those cells, and you don't have to go through that process again, because we already have the cells that we want growing inside this mouse that's going to produce the antibody that we want. And then purify it so they can use it in clinical applications, because you want to get all the mouse antigens and all that stuff, off them, so we won't have a big reaction because of the mouse non-self antigens in a patient. Now this is a very short list of some of the antibodies that are available right now, monoclonal antibodies, and that are actually being used. This one right here, rituximab. Oh, and notice that when you see mab on the end of the name of a drug, that's your clue. It's a monoclonal antibody. Now that one drug, rituximab, my mom, when she was living with me, I just took her for her regular, normal yearly exam, yearly blood work, and her and my intern said, her white count is just way too high. And I'm concerned about this. This is not normal. I've been seeing her for the last several years, and this is not a normal white count for her. Has she been sick? No. Has she been having any sweats? No. She's fine. It's nothing. I want you to take her to see the hematologist oncologist at Cancer Centers of whatever it is, Bullard. Okay. Went to see the specialist, and drew her blood and did some extra special kinds of tests. And the bad news was that she had chronic CML, I think it was, chronic myelogenous leukemia. And he kept saying, do you feel hot? Is she tired? I said, no, I wish we could make her tired. She's never tired. No, she's not having any of these things. She's not having any fever. He says, well, okay, that's good, but we need to figure out what we're going to do. So a monoclonal antibody was one of the choices of therapy. And we needed to do 4 different administrations. I think it was at 1 or 2 week intervals, and we bring her into the cancer center, they give her an injection, blah, blah, blah. I said, let's do that one. And of course, they have to tell you all the things that, like all the drug commercials on cable, and, you know, one of well, how do they say it? That they make these drugs sound so scary, you know. Some patients who take this drug have been known to turn purple and die. You know, those kinds of things. And it says, okay, but no, I love maths. I teach about maths. So we decided to do this one for treatments. Took her in for her first one. And, you know, if you've ever been in a cancer center, they have this big room and these recliners and all of these nurses and providers, and they come in and they do these IVs. It's an amazing kind of a place. And you go home when you're done. So we were sitting and did all the signing in, and she got her first administration. And then all of a sudden, out of the clear blue sky, she started to complain of severe back pain out of nowhere. And the nurse said, it's okay, it's a normal reaction to this drug. I don't get it, but okay. She stopped the infusion, and we waited for an hour, and then they gave her a high dose of Benadryl to sort of prepare the immune system, like settle down, the immune system. I know that you are seeing non-self antigens and you're not happy, and you're doing some degranulation and some inflammatory stuff that's going on. Settle down, gave her a high dose, and we waited again for that to get into her system. And they're waiting for mom to fall asleep. She is not going to fall asleep. She's talking me to death. So they came back and they gave her they turned it back on, and she was fine, just fine. Next time we went in, they gave her the high dose of Benadryl to start with, gave her infusion, no problem, no problem, no problem. At the end of the last treatment, we went in for like maybe a month later to get her blood drawn, and her CBC was better than normal. It was an absolute miraculous response, and she never had to go back. And when we went back to her internist again for her next regular yearly exam, did the CBC, and said, your CBC is great. You know, she had a very, very, very aggressive form of leukemia, right? I said, if you say so. I never saw any of that. You know, everything that the doc asked if she had, she didn't. Her blood looked terrible, but she went through this process, and she was an absolute cure. So I believe in this stuff, and I want them to make a whole lot of more of these, so that if me or a family member would ever have something like this again, I'm a believer. They're not benign. There are, you know, some side effects, but when they work and they're really specific against the thing you got, I would definitely consider this as you know, one of my first lines. So let's start when we get back here. And you guys can tell me if anybody in the house has had any experience with any other maths. Somebody.
I said your stories are different than Dr. Guzman's. His all end with the patient dying.
That's true.
Happy ending, right? Yeah, happy ending.
I didn't work for the cancer center, but I worked out front. But now I get to learn about it, and sorry you were so long. Yeah, there's
Perception, all the
mileage are. A lot. Yeah.